thank you, Kylie and Gray, for such a powerful panel and for sharing your stories. I feel like we should all just take a moment to appreciate them. And I really appreciate all of the folks that we have an opportunity to work with in whatever capacity who are willing to tell us how we can do better. My name is Aaron Jansen. I'm the Vice Chair of Child Psychiatry within the Pritzker Department of Psychiatry and Behavioral Health here at Lurie Children's Hospital. And it is my pleasure to introduce Dr. Lisa Simons, who will be presenting on adolescent and young adult suicide. Dr. Simons is an assistant professor of pediatrics in the Podesnak Family Division of Adolescent and Young Adult Medicine at the Ann and Robert H. Lurie Children's Hospital of Chicago. Dr. Simons is the director of Mental Health and Primary Care Program and has research interests that include healthcare for adolescents experiencing gender dysphoria, HIV prevention and treatment, LGBTQ health disparities, and healthcare for high-risk youth populations. Throughout the presentation, we encourage you to submit questions in the Q&A. We will respond to as many questions as possible after the presentation. And without further ado, Dr. Simons, take it away.
Thank you very much, Aaron. And since you know me to be perhaps the least technologically fluent person around, I just want to verify that you can see my screen right now.
Yes.
Awesome. So with that, we'll get started. All right. First, I just want to say, as a pediatrician specializing in adolescent health, and especially as a relative newcomer to this field of suicide prevention, I'm absolutely honored to participate today, and I'm humbled to be in the company of so many great leaders who have shared their work, their research, and their experience. I'm blown away and very grateful for the two presenters who just shared so much of their personal experience. Like usual, adolescents describe it, young adults, describe it best. So I'll try my best to add something, but I think I listened and am taking away important points there. So thank you. I'm also deeply grateful to each of you who are joining today in the midst of a pandemic that has only made these discussions even more important. I'm understanding that it takes a village, and I'm just really grateful to be here with you today. So with that, adolescent and young adult health. If we think about adolescence as everything that comes between childhood and adulthood, there's so much happening. There are physical changes of puberty that adolescents are adapting to. There are tons of social changes, right? Adolescents start hanging out with their friends more. Fitting in and acceptance becomes critical. Sexual and romantic relationships may develop, and for sure, family relationships remain important, but they may look a little different as teens, as youth seek autonomy, and parents adjust to that. There are also profound emotional and cognitive changes that are going on, which are thought to be related, at least in part, to enormous brain development that occurs during adolescence. Over time, teens slowly develop the ability to think abstractly, to regulate their emotions, to organize, to plan, and to make decisions, set goals for themselves. And as so many of you who work in different ways with youth already know, it's a privilege to be an observer to this incredible time of learning and growth and development. And also, as you may know, it's a time of both opportunity and some vulnerability. So the great health, adolescent health paradox that exists is that while adolescence is the time of peak physical health, right? There's not going to be another time in the lifespan where people are stronger usually. It's also a great time of morbidity and mortality. And often for adolescents, that's related to risk-taking or to impulsive behavior. This slide, I think, has been presented elsewhere, but again, showing the causes of death in the United States by age group in 2018, and showing that suicide was the second leading cause of death for youth ages 10 to 14 and 15 to 24. Many of us know, for some of us through our work, and for others of us perhaps even through personal reasons, that youth suicide represents a tragic loss of life, and also that it affects families and communities, schools, and multi-generational effects. Not only are suicides the second leading cause of death in adolescents and young adults, but as has been mentioned many times, the rates are rising here. According to the CDC, suicide rates among 10 to 24-year-olds increased 56% from 2007 to 17. We've seen ED and inpatient visits for adolescents at risk for suicide double in the past decade, and 120,000 youth are hospitalized for suicide attempts or ideation each year. So what does this look like in Illinois? Pretty similar. So in Illinois, suicide is the second leading cause of death in adolescents aged 10 to 14 years, and the third leading cause of death in adolescents 10 to 19 years, coming behind homicide. In 2018, according to the Illinois Violent Death Reporting System, 132 young people aged 10 to 19 died by suicide. And when that age range was expanded in the same year, the CDC reports 201 young people died by suicide in the state of Illinois. And I think several of us have mentioned suicide trends that are described in the 2019 Youth Risk Behavior Survey, but I think it's worthwhile reviewing again. So again, this is a survey that's conducted by the CDC every 2 years that surveys 9th through 12th graders across the country in public schools and in private schools, and asks about a range of health-related behaviors, including suicide. So I've highlighted here the 2019 results, which is the most recent YRBS, and whether or not that rate represents a change from previous years. There are 4 questions related to adolescent suicide that asks about behaviors and attempts in the 12 months prior to the survey. And as you can see, 18.8% of respondents, essentially 1 in 5 high school students, had seriously considered attempting suicide. 15.7% had actually described making a suicide plan. 8.9% reported having attempted suicide at least one time during the 12 months prior to the survey. And 2.5% reported making a suicide that ultimately required medical evaluation or treatment. And I just want to point out that these numbers may be artificially low, because remember, we are capturing in this data only youth who are in school. And other high-risk populations, including homeless youth, may not be included here if they are not in school. There were differences amongst each responses. So consistent with previous research, females had more suicidal ideation, suicidal plans, and attempts, including attempts that required medical evaluation. There were no differences in attempted suicide by grade or a proxy for age. But as discussed in several other presentations, Black students had the highest rates of attempted suicide. And the next slide, we'll look at some more disparities, which are going to be really important as we understand more and in order to tailor our care and interventions. So again, there are significant disparities in suicide and suicidal behaviors. In terms of gender disparities, while rates of suicide have increased in for both males and females, rates remain higher for males. Dr. Benton's presentation so thoroughly described the alarming changes that we're seeing in suicidal rates and behaviors in Black adolescents and young adults. And Dr. Hoffman, I think after this presentation or in later presentations, will be describing rates of suicide and differences in rural and urban communities. So I'm going to take this time to focus a little bit more on sexual orientation and gender identity. And it is well known that the LGBT, the lesbian, gay, bisexual, and transgender population are disproportionately at high risk for suicide and suicide attempts. Here I've listed some statistics from the 2019 YRBS. First, lesbian, gay, and bisexual adolescents are almost 5 times as likely than their heterosexual peers to attempt suicide, and they're also more likely to require medical treatment for a suicide attempt. 35% of transgender adolescents and young adults in the YRBS reported attempting suicide. That was much higher than the 5.5% of cisgender males and 9% of cisgender females who reported suicide. And again, those are staggering numbers, right? And as a pediatrician, I'm thinking, I'm pretty blown away by those. And as a pediatrician that also works with our children's hospitals gender development program, I can not only vouch for those numbers, but I also think they look a little bit low, that 35% of transgender adolescents. And actually in other studies, the numbers are have been even higher. And I wonder in part if that is because of what I mentioned earlier about, at least in part, about people who are not captured in this survey because they're not necessarily in school. So LGBT youth, and in particular transgender youth, due to much higher rates of victimization at school, are more likely to drop out. They're also overrepresented in the disproportionately, represented in the homeless youth population. So those are important things to think about, when we're looking at these numbers. Similar to other marginalized communities, there is nothing innately biologically inherent to being LGBTQ that predisposes one to either suicide or depression. What causes depression and suicidal behaviors and suicides and a whole host of other negative health outcomes is presumed to be related to the experience that these minorities experience in society. This picture, which I'm realizing now that you can't see, so I apologize, but I hope you'll take my word on it. I can describe it. Describes what I think this boils down to, which is the experience of rejection and lack of acceptance that occurs on so many different levels. So here you see it occurring at an individual level with internalized homophobia or transphobia. We can think of rejection occurring on an individual level. Think about rejection from family members, from peers. In a next level, we can think about rejection that occurs on the community level. And here I'm thinking about other YRBS data that I didn't describe that really, again, describes staggering numbers of reports of harassment, that being verbal harassment, physical harassment, and even sexual harassment that LGBT students experience in schools. And I'll say from my experience working in the gender program, sometimes that harassment, especially the verbal harassment, is often from peers, and it's sometimes from staff too. And so that's, deeply troubling, and I think an area that we can certainly intervene on. We know that connection to peers, to community, being involved in sports teams and things like that is so important. We know that from general research on adolescent health, and we also know about it from what's been going on during COVID. We see disruptions of those connections really having, horrible effects on people's mental health, right? The loss of connection to those accepting places, to being able to develop self-esteem and self-worth. And I think about those places not being safe for LGBT communities, for this very vulnerable community. That to me is a huge area that we all can think about and, hope to change together. Actually, before I go on, I'll also mention that we're also seeing rejection occur on greater levels. So, just as one example, a few years ago, we were seeing the bathroom bills that would not allow transgender youth to use the restrooms that they feel most comfortable using in schools. But more recently, we see countless proposed and sometimes passed legislature trying to limit things like access to sports and even healthcare. So these are really dangerous. And I kind of think about what kind of messages these things, these send to youth, to adolescents and young adults during such a critical time in their lives. So now I'll get to this slide and mention that emerging research is highlighting that rates of attempted suicide may vary between different gender identities. This study by Toomey et al. Interviewed or surveyed over 120,000 adolescents age 11 to 19 years and found within that 14% of the entire sample reported previous suicide attempts. But when you broke that down by gender identity, we found much higher rates in the transgender students. So in this study, found 50% of affirmed males, those were assigned females at birth, who reported attempting suicide, and 41% of non-binary identified adolescents as having reported suicidal attempts. I just want to make a plug for more population data and note that 2017 was the very first time that the YRBS included a question about gender identity. And in fact, only some of the states in large urban areas piloted that question. And it is so vital. I don't know how we can think about, really reaching communities and populations if we don't know who they are and what their experience is. So that population data that is emerging is so vital. And the last point is that gender affirmation, access to health, to healthcare, to gender affirming healthcare and safe learning environments are just critical to transgender youth. And since, I have a captive audience, I'll share, some research literature that describes just using someone's, the names and the pronouns that they use can be linked to reduce depressive symptoms and suicidality in youth. And more anecdotally, but I think, Dr. Jansen would agree that this is probably not unique. We have youth describe pretty horrible experiences during a hospitalization for a suicide attempt or suicidal ideation. So that kind of treatment that is not affirming at a time when someone is so vulnerable, that's another something that we all, and I'm, hoping people on this conference can think about as well. So back to adolescent population as a whole, here's some risk factors that are probably now familiar to us for suicide and suicidal behavior in adolescents and young adults. We see previous suicide attempts, mental health problems, family history of suicide and suicidal attempts, sexual and gender minorities, adverse life circumstances, recent stress, abuse, trauma, neglect, and bullying, and access to lethal means. And protective factors are important to know about as well, including religiosity and that connection that we were just talking about. I also appreciated Dr. Benton's comments about really learning more about risk factors for unique populations and really understanding that in order to be able to tailor our interventions. So this may be going off on a tangent, but I hope you'll indulge me. Going back to, first I'll share, and maybe it's too much information, but I think for a while, it took me a while to wrap my head around the fact that, about the number of youth who were not experiencing, or were at least not known to experience, depression or mental health problems. Because I thought that screening, we should be able to reach suicide by screening for depression. And now we know from many different presentations that that is not correct. And I'm thinking about what's going on as an adolescent physician in that population who did not have mental health problems that were known. And I'm wondering if this framework, or going back to the idea that during adolescence, there's a lot of brain development, right? Essentially, the brain gets a facelift. And one proposed theory to explain the increased risk-taking behavior that is seen during adolescence is the neurobiological model, which essentially points to two different brain systems and the relative difference in their development. So, those two systems being here captured on the red line, the ventral striatum, which represents here the social emotional part of the brain, the amygdala and other centers that are responsible, thought to be responsible for impulsive behavior, for risk-taking, sensation seeking. That develops early as compared to the very gradual development of the prefrontal cortex, which is responsible for things like impulse control. So that is not to say that every adolescent is, every adolescent is at risk for suicide, but it makes me think about impulsive behaviors and how we strategize to make environments safer, knowing that there may be a bias towards impulsive behavior during adolescence. So thank you for that indulgence. I'll get back to suicide prevention. And so many of these were covered extensively in other presentations. So I'll say a few words about screening and identification of at-risk youth in particular. So again, I think it cannot be overstated that specific screening for suicide and not only depression is really vital. It's been said before, but I will say it one more time, that there is no evidence to suggest that asking someone about suicide prompts more suicidal thoughts or behaviors. In adolescent health, I think the pediatric providers would be familiar here with the HEADS psychosocial screening. There are many different forms of it, but it is very routine for us to be asking about things like mental health, mood, anxiety, suicide, and substance use. It's also important to recognize how signs of depression and substance use can look different in adolescents and young adults. They may not say that they are depressed or feeling low, and that may look like irritability and anger or boredom. I get a lot of that as well. Some people may not have the words to express what they're feeling, so they may present with more somatic complaints. This one patient that I saw fairly recently, a 14-year-old cisgender female who had immigrated from Jordan about a year prior to her being referred to me for evaluation of irregular periods and pelvic pain, low score on the PHQ-9, totally negative heads, nothing, in our discussion to suggest that she would be at higher risk for suicide. And when I was doing her exam, I noticed significant evidence of self-harm. And that prompted more conversation about suicide. And she in fact did have suicidal ideation. So this patient is just a reminder to me of how important it is to be vigilant and to screen directly. So I'm excited to be part of a team here at Lurie that will be thinking through implementation of this as just one part of suicide strategy. This has also been said before, but again, healthcare providers, it's so important for us to continuously screen because of the data that shows that people who have completed suicide did have contact often with primary care providers in the year and even in the month before suicide. So these are all opportunities for us. Anyone who screens positive should be, should have an assessment that includes identifying all of these things. And I know that has been described, so I'm going to go on and just, I have a sense that I'm preaching to the choir. So I'm going to share these tips, knowing that a lot of you already are the professionals here, but just a reminder to think about your space, think about inclusion, what do the forms look like? Are you making, are you intentionally showing signs that you are welcoming the communities that you want to care for? Always, important to talk alone, to discuss confidentiality and the limits thereof. Explain why you're asking. Don't just, dive right in. I think it's helpful to talk about these things, to introduce why, but then ask directly and practice, because adolescents will call you out if you're not comfortable and they just won't share that information. I think we covered these, in different slides, but I just want to end with who has a role to play, and that's all of us here. And so, for many reasons, it's so important that we address these in systems level, that we work together and collaborate, that we include people who have lived experience and others as well. So thank you.
Thank you so much, Dr. Simons, for your talk. I think we have time for a few questions if folks want to enter any in the Q&A before our next session, which we actually have a break between now and 3:40. But maybe I will take the privilege of asking the first question. And I'm curious, specifically among the LGBTQ population, what are the implications or thoughts about network effects of suicide? And what I mean is, certainly I think we see clusters and communities of support where folks who are LGBT do have such higher rates of suicide attempts. And so there are increased rates among colleagues, friends who have attempted. And I'm just curious your thoughts on that, and if you can speak to any.
Yeah, it's a good question. And I think, like many things, it's something that we need to understand more about. I think sometimes families come in worried that, that young people are surrounded by other people who could potentially, they're impressionable, and, are they, mimicking in some way what their peers are. And, again, I think we need to know more about this, but, one thing I think is clear in that there's another explanation for why we see those clusters, and that sometimes, I think about fitting in shared experiences, and especially with marginalized young people, how important it is to find other people who are accepting and who understand, your experience. And so I think that we see these clusters in part because of that. And, it's it's hard to fake depression and suicide, right? And so I think, what I would say is that I take anytime someone brings up concerns about suicide, I am taking it as real, and something that needs to be addressed seriously.
Thank you. And I know we're out of time, but I think this is such an important question that just got entered. So I just want to give you a chance to respond to this. How do you think mental health and medical providers and facilities can foster comfort in queer, trans, Black, Indigenous, and people of color? For example, how can a children's hospital foster connections with trans and intersex youth, especially given the turbulent past? And I think we in the psychiatric field have a lot to apologize for in terms of this. So I'd love to get your thoughts on that before we wrap up to go to break.
I think that is a huge question, and it's hard to, come up with a simple answer to that. But I think the first part is really listening and talking to exactly those communities. I think we will do a better job every field by including those voices. And so, I would be humble and say that I think, those communities probably have really great ideas of what needs to happen to foster trust.